Hey everyone, welcome to the Behavior Business Roundtable. This is a show where we take a hard look at the current state of behavior analysis, business ownership, leadership, ethics, and service delivery. I'm Kyle. I'll be moderating this panel of esteemed guests and hopefully keeping the peace as we take a look at some topics in behavior analysis today. We're going to take a good look at some systems kind of shaping our field, talk about what's working, what's not working, and what kind of meaningful improvement we could be making for both recipients of services and practitioners alike. Today's our first episode. We're calling it the Quality Crisis in ABA, and our topic is let's talk quality today. Before we do that, let's introduce our panel. Dr. Sparks, you want to go first?
Sure. I am Steve Sparks, unless I'm in a situation where the doctor fits. But for the most part, if you see me at a conference, say, "Hey, Steve, what's up?" I own Sparks Behavioral Services, Homes Residential Care LLC, which is a behavior analytic housing company for people with severe behavior needs, and kind of owner of Cooperant Learning. It's a subset of Sparks Behavioral Services, but Kyle runs the show here, so I can't really take credit there.
I do run the show. Thank you. I'll interrupt that. Taylor, go ahead.
All right, my name is Taylor Barker. I am the owner and clinical director of Ebb and Flow ABA Therapy in Michigan.
And last but not least, Kristen.
Hi, I'm Dr. Kristen Byra, but as Steve said, I'm just Kristen when you see me out in public. I am the founder and CEO of Upskill ABA. I build clinical decision support systems and also do consultation and mentorship to ABA clinics.
Excellent. All right. So the rules of this are pretty simple. I'll explain them here. We'll present a prompt. Each panelist will get 60 seconds to respond to said prompt. At the end, we'll have some time for agreement or respectful rebuttal. And after all the prompts, we'll get some time for some closing remarks. We drew straws beforehand, and it looks like Kristen is up first. So Kristen, the first question in our episode today is, what do we actually mean by quality in applied behavior analysis?
Great questions. Hard to answer in 60 seconds, but I think quality without measurement is just marketing. I see it on every website of every ABA company. It's that we lead with quality. We care about quality. That's not enough for me. So I actually developed a 28 question assessment. It's yes, no, it's binary. It's not I do it sometimes or a little bit. It's either you do it or you don't across 5 different areas. I care a whole lot about data analysis. I care a lot about caregiver guidance, supervision, looking at our daily sessions, and treatment fidelity. All of us went to Western, and I think all of us remember Dr. Malott would tell us we should not know our client at their next birthday. And while that's a bit of an ambitious statement, I do think we should be actively working ourselves out of a job and be thinking and planning for that the second that kiddo comes into our care. And that's where I think we start talking about quality.
Extra points for ending with several seconds to spare. Way to go. Steve, you're up next. What do we mean by quality in ABA?
Don't worry, I'll use those extra seconds. No, I think generally what Kristen says is what we should kind of use as a yardstick on a day-to-day basis. Our planning, is it being implemented correctly? Is it designed well? Are we putting the right amount of time, not too much time? But I think there's also a lot of different ways you can look at quality in behavior analysis in general. And we have to remember, I know not a popular name nowadays, but when Lovaas kind of developed this approach back in the 70s in the discrete trial training, we have to remember that it was, all right, you have the specialist there that could sit in there one-on-one, shape behavior in real time and really make a lot of great success, but then they can only work with 1 or 2 people. So this whole model was, all right, train BCBAs that may not be quite the same level or haven't gotten there yet, and then use technicians who are obviously not that level and design this system that it's not the highest quality, but is it still effective and efficient? And then where have we slipped off from there is kind of the question.
1 minute exactly. I'm going to be super impressed at your guys' time management during this. But good points as well, Steve. Taylor, same question.
Yeah, absolutely. And I think I can piggyback off of both of those to maybe a little bit greater degree in the sense of Kristen's. and looking at, are our clients meeting their treatment goals? Are we making that progress? And in the treatment planning process and whether you want to call them insurance reports or whatever, are we meeting those goals on that timely process or on that timely timeline? And then from Steve's point, I think we have a social validity problem in our field. I think both from our employees, from our organizations, from the general public. And I think if we're able to create systems, and again, like Kristen said, everyone's website says we're quality, 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 quality. But if we're able to create organizational systems where our staff love wanting to come to work and say, I don't want to leave ABA, I love being an RBT. And then our consumers, so the parents of our kids are saying, yes, ABA was great. I loved it. I was so happy when I got my kid in ABA. And I think that social validity piece is just as important as a metric for quality.
Kristen, do you want to talk about this yes/no assessment a little more detail? I was curious about that.
Sure. I do think that we have kind of lost our way of what are we really looking at. And we showed up, did we take some data, and then people check out at the end of the day. And I think we've maybe lost kind of what we should be looking at in those areas. So as I mentioned, it is binary. It's either yes, I do these things, or I don't. So in particular, I also borrowed this from our experience at Western. I asked whether or not we are reviewing static progress every 10 sessions. Are we looking at 10 sessions and saying things are going well, they're not going well, I need to investigate, but we're doing something in that 10 sessions? And if not, then I do not give you a point for that response. That is a no. And I recommend that you start engaging in that practice. So the assessment itself will go through those 28 questions, but it's not just a doom and gloom if you're not doing all of the things. It's also then going to show you, hey, this is why this particular question was selected in terms of the research or our standards of care in our field, or ethical code of conduct that we should be following, those types of things. And there's a whole bunch of free job aids and different resources to help you if you want to start engaging of, oh, hey, I'm not doing that right now. Why should I and how should I? That's also included. And it's free.
I don't have the air horn, but if I could play it, I would. Maybe I'll add it in post for that part. Any other follow-up or agreement, rebuttal from anyone else?
I have a follow-up too for Taylor. I think that treatment plan component being so important. I think folks get to the end of their authorization, and if they don't meet all the goals, they're like, oh, well, like we'll just do it next time. Oh, well. And then we see goals that have been in treatment plans for 12 months, 18 months, 2 years. And there's no narrative of how we assessed barriers, adjudicated those barriers. We're just, oops, we didn't meet it, and we'll just try better next time.
Yeah, I think there's also an issue with that, with the goals being somewhat arbitrary at times. We have to come up with goals just to fit this. It may not be our goal, but the goal we want to teach is going to take significantly longer than this, or many sessions. And so because of that, we're going to come up with all these arbitrary things just to make it look like we're making progress, rather than are we actually making progress to the goal. But I do like, Kristen, what you're working on, because it really does see like a lot of the gap is between in school, you had all the time in the world to help one or two kiddos. You're working with them. You're trying to design these programs. And now how do you translate that to a work environment where you have to have work-life balance and actually help people, but in the way society wants you to? And I think that is where the biggest gap has been is, all right, are we actually being able to do the same quality under these new constraints that we're not used to working in?
Well, that's a good segue to question 2. Before I read it, I did want to read some findings from Blackman et al. 2024. Talks about behavior analysts. Many leave their workplace due to, quote, workplace challenges or too many or not enough hours, promotion at another agency in the same field, or for personal reasons. But 52% cite burnout as a reason for turnover. Second question, and Steve, we'll start with you this time. Is the high BCBA turnover rate, is it a workforce problem, or is this a systems problem?
It's both, and it's partially because our systems don't necessarily work into or fit into the traditional workforce models, and that's a big part of the issue. But I think what's really happened is it's like any other new field or up and coming field, is that bubble, whether it be real estate or looking at tech and those bubbles as well, where we had the small shops that worked for a long time and the money was there. It wasn't necessarily great, but everybody was living. It was sustainable. Then you had the private equity come in, and they could offer so much more because they didn't need to have as much profit per unit or per service. And so now you're trying to keep up with these things, even though the money's not there, it's not coming in. And if you survive, and once the bubble bursts, which it seems like it might be starting to now, then you will probably be in good enough shape. But will you survive that long? And will the BCBAs be willing to come back where they can't quite make as much money? Or even though the quality of life should be significantly better, you're not being overworked,
Taylor, same question.
I think it is 100% a systems problem. That's an organizational leadership, organizational arrangement problem. I think as an example, when I finished grad school, I moved to Indiana because there weren't services in Michigan, and I worked for a nonprofit, and it was great. I loved it. The way the system was organized, it being a nonprofit, everything was amazing. I would have worked there the entirety of my career. My family decided to move back to Michigan, and in a essentially 18-month period, I worked for 4 different organizations because I could not find one that fit and aligned with my value systems, with those quality metrics, with clinical outcomes actually happening. And that is actually what drove me to start my organization, because I knew it could be done. I knew it could be done in a solvent way where reimbursement rates were able to support the organization, and we were able to design a culture and a service delivery model that fit that, where people still, like I said in the last question, wanted to come to work, right? Where it was, this is enjoyable as a field. I want to do this work.
I've just now decided to give out points during this, and some points for Indiana there. So Taylor, you're currently winning. So
all right, perfect.
Kristen, last time, up to you.
I also think it's a systems problem, and I'm not trying to throw shade on BCBAs. I think they have a lot of competing contingencies too, but I see, BTs and RBTs wanting to leave because they do not feel supported during their supervision sessions. They have BCBAs that are showing up, right? It's like, oh, it's Monday at 10 and I'm here. And like, what do you want to talk about today? Or what are you working on? And just keep doing what you're doing. There's no forethought. There's no planning, right? And then when those things happen, then we also have clients who are not making progress. And I don't know about you, but I don't really like showing up to work every day where I don't think that what I'm doing is actually making a difference. If my kiddo couldn't tie their shoes back in January, and here we are at the end of April, and we've made zero amount of progress, what am I doing here, folks? Why am I coming into work today? And so when we don't have that kind of pre-planning, that preparation, we're not looking at our data in a timely fashion, we're not making those meaningful metrics move, then people leave.
Yeah, you've all kind of touched on similar topics here that it kind of foreshadows into later questions too. But Steve, you kind of referenced these like workforce models and maybe how the way that our field has evolved, it's not, the workforce model isn't very supportive, or do you want to elaborate on that a little bit? Like it doesn't fall in line with what a typical workforce model is and what you meant by that?
Yeah, the traditional model is you go to work, you do your work, you get your paycheck, you go home. And that is, I think, where a lot of people that, and I don't want to say there's a difference necessarily between programs, because I think people can go through any program and see that. But a lot of our new BCBAs going through these online programs, they're not immersed in this culture where we're expected to work 50, 60, 70 hours a week just to get through school. They are still in that traditional mindset of I go in, do my work, go home. As long as I'm making a good plan and giving good supervision, it's not my fault if, the person isn't making good progress. And so because of this issue, we expect everybody to want to be what, we went through school expecting to be. And I don't think that that's the way the world necessarily works. And that was going to be my feedback to the others as well, as I'm 100% with you. But if you are coming from this traditional model of I just should be able to do my job, go home, make good money, and not, be overworked or mistreated based on what's expected of me, then I think you're not going to necessarily be happy coming into some of these situations in this field. And so if I have to work 90 hours to get as much pay as I think I deserve, then the outcomes in the session may not be enough to reinforce it, or that extra support may not be enough to be reinforcing comparatively these other places that offer all these things, that it's a good work-life balance, can't pay me as much. And so now that's aversive. Work-life balance is aversive. One way or the other, I'm losing out. And that's what I meant really by these, the bigger companies coming in is we can't blame the rat. We can't blame our technicians or our BCBAs. If they're going to the money, that's where they would go because that's the reinforcement. But now all alternatives look punishing. And therefore, are we thinking about leaving the field now because I'm burnt out with one end, but I can't make enough money in the other side?
Any rebuttal or agreement to that?
I could give Steve a rebuttal for everything, man. I could argue with Steve all day. I guess I have a follow-up question then to you, Steve. What did you mean necessarily by that 80, 90 hours a week? Was that you're going through grad school while working full-time, or is that I work for a clinic that's open 80 hours a week? And so
I was over-exaggerating exactly the number, but I'm just saying the work-life balance. It is, I know a lot of people who are saying they're working 60 hours a week or more to get their billable hours in and do all the extra things.
Okay.
I've known people that are in.
So you're a BCBA, you're wrapped up. Okay.
Well, in grad school too, it was well over 40 hours a week we were putting in through that process. And so I'm saying those of us that went through that, where it was like you have no personal life, you're just in school, are going to have different expectations than those who are doing this while working and raising a family and just taking classes on the side. Is really what I
think that's maybe where my follow-up was to your part about people in grad school. So at least at my organization, we follow Brian Hartley's apprentice model. And so I do have a conversation with my new apprentices when they come in. And I use this as an example. And again, not to say you're going to be expected to do this, but I think all of us are old enough on the call to have watched like Grey's Anatomy, and where it's like those Grey's Anatomy interns, they were sleeping in the closet at the hospital because they were there 24/7 for like 3 weeks straight. So I was like, we're not doing that here, but you're going to be expected as part of being in this apprentice program and me providing your supervision. You're going to work here 40 hours a week, but I'm going to expect more out of you than just what you can get done in your allotted work time, because that's what's going to take to make you a good clinician and be able to provide that quality.
And I think if you put that ahead of time, you will have those that come will stay and it will work very well. Right. But those that won't may leave, and then you may have a workforce problem if there's too many that don't accept that. That's what.
Yeah, and that I think ties into our question later on in our thing. So I'll stop now because I see Kristen has her hand up. Kristen, and she's too nice to cut us off, Steve.
You gotta cut them off.
I will. Don't worry. the snaps will come. But Taylor, you're laying out like during your graduate program, like you're putting these extra hours, but I think that's what's going to help them have that work-life balance that, Steve, you're saying like, oh, they need all this extra time on top of their billables, like that's another conversation. But in terms of outside of the billables, it's like not being reimbursed. I think folks are spending so much time on those types of things because they didn't get the training to make them proficient. And so I think the system problem that we're seeing too is the training and preparation. They didn't do something like what Taylor is offering. They didn't go through like our kind of experience. I wrote a newsletter about this. Like we've taught them during their supervision how to make like mac and cheese, like Kraft Dinner style, like get like boiling water, dump in the box and like put some powder in there and you got mac and cheese. Then they're coming into an organization. They're like, hey, from scratch, go make like a, mac and cheese with some Gruyere cheese and like toasted crumble on top with bacon. And they're like, what? I don't even know where to start. I thought you just boil water and dump shit in it. Sorry,
I like that analogy, Kristen.
And then, right. And so I think that's where, in terms of like Steve saying they're so overwhelmed, they're so burnt out, I'm working 80 hours a week. I think because the task that should be taking them maybe us a half an hour or 45 minutes is taking them 3 hours, 4 hours, 5 hours, or like they're still struggling. They just don't even do it because they're paralyzed by like, I've never done that and don't know how. I think that's where all that extra time is coming because they're in a position they're not fully prepared for. And that's not shame on them. It's shame on whoever said, hey, you're ready. Go spread your wings and fly as a clinician without any mentorship and support and like, hope you do okay. And that's when they're working 80 hours a week because they're floundering, trying to make from scratch mac and cheese.
Yeah, and talking about that, I'd say, Kyle, take us to the next question because I think we can almost continue the conversation from that point right there into that next question.
Yeah, well, I'm the host. I'll decide when we go into the
No.
next question, but it is a good segue. Yeah, no, I've not framed it that way, though. It is interesting to think about I don't think of burnout rooted in supervision and the supervision experience, but I'm framing it that way now as I hear you all talk. That maybe some things that I, as a supervisor, signed off on that I was like, yeah, they'll get it. They're close enough. Like maybe that's attributing to the burnout as well. That's an interesting take. Our third question, and it's Taylor, you're the first on this one. How would you define an organizational cycle of mediocrity and how agencies get stuck in that cycle?
Okay. I think I'm going to have a hard time sticking this to 60 seconds, but I think it ties into maybe how I answered my very first question, in that organizational cycle of mediocrity maybe is predicated on a lack, maybe not a lack of, because I don't want to maybe throw any organization under the bus, but that lack of urgency or agency related to clinical outcomes, right? That we're going through the steps and going through the process. And I've seen these in some of these places where maybe like a Facebook group that's like a non-BCBA owned Facebook support group, right? Where it's like someone who's not a BCBA, it's like you don't have not necessarily any clinical experience, but you don't have the groundwork and the framework for what behavior analysis is. And you're looking to start this organization. And yes, great for you. Maybe there was a need in that area or whatever, but if it's not rooted in needing to focus on clinical outcomes and instead is related to maybe organizational sustainability, I think sometimes our organizational decision-making processes are rooted more in how can we keep the business sustainable as opposed to how can we make sure we're producing quality outcomes and then worry about the sustainability of the business.
Kristen, your take, go ahead.
I think sometimes organizations fall under like faulty measurement tools. So for example, we're going to just bang on treatment plans today, me and Taylor. We must be doing okay because the funder accepted our plan. Wrong answer. Okay. So for those of you who don't spend a lot of time in funder land, I do. And like there are many, many plans that are just administratively approved because they just ran out of time to actually read your request. Right. And it is less risky to go ahead and approve those hours and cheaper than to deny it or like delay it. So then they have to they're going to get a lawsuit because there was, a gap in services or you denied it for an arbitrary reason. So it is safer. There is less risk issues with the insurance company. Just approve hours, never even reading it. So when folks are saying, well, our denial rate is great. Wrong answer. That is not the measurement tool to determine whether or not you're doing great quality work. Let's put it that way.
1 minute on the nose. Steve, go ahead.
I'm going to take the opposite approach because I don't work in early intervention. We're doing the assessment treatment of severe behavior mostly over here. And from a more macro business perspective, I think what happens a lot of time is, you hit a issue. It's either growth, you're scrambling to grow, trying to get people in place, hire without having necessarily the money there, trying to figure everything into place. And then you finally get to a point where you're like, I can breathe and relax. And instead of planning and setting up systems to, sustain what you have going on, you take sit back for a moment. And then all of a sudden the next emergency comes and the next emergency comes. And you never get to the point of we're just kind of floating and hanging out there. And then you look back a few years later and you're like, oh shit, didn't do any of those things. Now this is a mess and this is a mess. I've been letting people just do their thing and the quality of care is down. And it's just a lot of that's not there because you're not putting in all the checks and balances and things you could have early on to prevent mediocrity in the future.
I think there's a difference too between like operational compliance and then actual clinical quality. And I think people use that term like quality assurance. It is really just compliance, like checking boxes. Did everyone do their HIPAA training this year? Like, yep, did it. Like, are people actually engaging? inappropriate HIPAA practices then? Or you just check the box that everyone has their certificate. So if we're audited, then we can, produce some documentation, as opposed to putting those things like into practice. And I think that's where I see that mediocrity, like, well, we did the thing. We did the bare minimum. So we're not going to have clawbacks from the insurance company. We're we're engaging in like avoidance tasks. So like we're not losing money and things like that, as opposed to Steve was mentioning kind of like forecasting, like actively being proactive of like, how do we prevent these problems from happening? Like we're not just in a mindset of bare minimum so that we can just continue to bill. I'll leave it there.
Yeah, go ahead, Taylor.
I like that topic of operational compliance, Kristen. And I think I'm going to elaborate on that a little bit. And I always like giving my own personal examples. And so this may be nuanced just to me. But so when I finished grad school, I worked in Indiana, which was arguably the first state in the country to have a insurance mandate for ABA services. So they were one of the very first states to have these organizations set up. A lot of them were rooted in or created by parents and other behavior analysts. So like the intentions were there. We were looking at outcomes. When I moved back to Michigan being one of the last 25% of the states in the country to have an autism insurance mandate, I came back here and I saw where because there was already a propensity of service providers in this country that kind of moved into Michigan and capitalized on Michigan, there were situations, and a lot of situations, where organizations were just operating under an operational compliance model. And I can give a couple examples. I know we're pressed on time, but like our authorizations or insurance funder authorizations, and I can pick specifically on Medicaid, but where it's once that kid's 7, he only gets 20 hours a week. And I'm going, well, wait, this kid right here, profound autism, severely significant maladaptive behaviors. Like this is a clear-cut case, and we don't need to argue in this podcast on like older kids and full-time services, but this was a very clear case of this kid needs 35, 40, maybe 45 hours, right? Once you bounce over that 40, then it's an argument too, but like clinically, medically necessary based on our assessment tools and all that. And it's, oh, nope, he only gets 20. And it's like, well, why? Why are we not appealing this? Why are we not using mental health parity law violations? Why are we not going through first level, second level, third level appeal, insurance, the state's level Department of Insurance appeals to fight this? And it's nope, because that's what we do, because that was this model in the system when we moved into this state, to not ruffle any feathers. And I think like Steve was saying earlier, we just don't have the bandwidth as an organization to make it profitable if we're then spending money to go through those appeals. I know me as a mom and pop shop, right? We've got one location now. It takes me longer to appeal the money we lost in my lost revenues than it would be if we got the money. So like I'm losing money to get that money that I didn't get, or to get those hours that I didn't get. So I think it's another maybe an example of that kind of operational compliance, kind of watering down or creating what was the original question of that organizational cycle of mediocrity.
And just to tie it back to the first question, and then we can go on, but what I was saying about the what is quality care ties into that as well, with like 20 hours, 40 hours. If you had a really masterful BCBA that spent all their time with one kid, that would be the greatest level of care, but it would cost $100,000 a year per kid for the system. They can only help one child at a time, probably. And so is that better quality of care for the system or for that one kid? And how do you balance that? And I don't think society has an answer for some of those questions either.
Thought-provoking stuff. Okay, let's go on to the next one. Kristen, you're up first this time. The role of the RBT, is this a sustainable career path?
Oh, goodness. I'm glad I got chose first for this one. So, I mean, I'm going to be obnoxious and say I think it depends on where you work. I have seen some agencies really grow that role past, just doing direct services, where they are moving into, trainer models and things like that kind of piece. But that then makes that a different role, right? They're not just a direct care billing 5-3 as their only job. I don't know. I'm going to be obnoxious. I'm not really sure, and give my extra free time to Stephen Taylor.
Oh, don't give extra time to Steve. That's always bad news. Steve, you're up next, though. Go ahead. I'm keeping it at a minute, though.
All right. So I think it's not a clear question because it's about the system again, the system as a whole. I don't think anybody is willing to make $15, $20 an hour for the rest of their life necessarily, unless they really love the work and they don't need the income. They have someone else or another source of income. But you're also running into constraints with, all right, how much can we pay an RBT to the point where now we could just have a BCBA doing the work as well. And so I know times have changed, but going back, starting off at $65,000 a year, and the BCBA is only breaking that down 40 hours a week at $33 an hour or $31 an hour. At $70,000 a year, it's like $33, and at $80,000 a year, it's $38 an hour. When you really break that down the way it works, at what point are the RBTs almost making as much as the BCBA, and the BCBAs are going to say, hey, why don't you value me more than this person that's working under me?
Taylor, you're up.
My quick answer is no. It's not a sustainable career path. And I would kind of say a lot of that's based on funder reimbursement rates. And I'm going to tie it right back to the money, because when I was certified in 2011, and essentially, at least for the Midwest, excluding the ultra large cities, so like excluding Chicago, the RBT wage has remained static for about 15, 16 years. So 16 years ago, $18 an hour was worth a lot more than $18 an hour is now. And insurance rates have only either remained static or decreased since 2010. So I would argue it's a funder reimbursement rate, and I think a rate issue. And I think the impossible wall that we're having to climb is the fact that the diagnostic rate for children with autism has only gone through the roof, and insurances are bleeding dry, and it's going to be an uphill struggle to try to increase these rates. Kristen,
you some follow-up.
Yeah, I'm going to take my 23 seconds back. Just to tag on to Taylor, I don't think it's just the funder reimbursement rate, which I do agree is a problem. I also think there's the rules that surround that too. I know at least here in Arizona for Medicaid, like you are not allowed to charge cancellation rates. Like you can't charge the family anything for missing appointments, which if I go to my physical, if I have physical therapy, if like anything that I don't show up for, like I'm being billed as a patient, right? Because you've taken someone else's time. Like I can't see someone else. But again, I'm not getting my annual physical done every day. Right. And so like, I understand why there's those protections in place, but I do see that being super problematic. Steve saying, are we going to pay them as much as a BCBA? The problem is BCBA. I know there's options for hourly BCBAs, like tons of them. I get, an email on LinkedIn 17 times a day. But if I want a salary role, like there are plenty of those available, right? Where I can have consistent salary, income, benefits that I don't know any organization that's offering salary RBT positions. You have a cancellation that day, sucks to be you.
Yeah. We used to, but we started having issues with people finding reasons that the visit was canceled. And so it is actually easier to go away from that, even though we much preferred it. Taylor, just go back to what you were saying about the funding. And I think, again, the problem is society as a whole. Where do we put our money in? Is it new wars in random countries, or is it, medical services for people? But I just did the quick math using some, Google search. Up to $100,000 per kid for ABA services, around like it can't be that or more per year. That's costing the system, and there's around 9,000 children in Michigan right now receiving that. So we're talking about $900 million of our insurance money going to that. we have to figure out a way to make it sustainable both for the system and for the companies, and nobody is working together on that. And I think that's the biggest issue here. Isn't that I disagree, because there's not enough coming in for us to pay technicians what they should be to get them to stay around, or even BCBAs, unless you're a larger company for that matter, a lot of the time. But also, if the money's not in the system, then what do you do there?
There's the money side, and there's also just the kind of going back to that burnout side too. I feel like every day on the subreddits, at least, I see like some cryptic posts like I can't do this field anymore. I quit today. I left crying, and then an explanation of how I've got a super aggressive consumer I work with. I'm an RBT. I get 1 hour supervision a month from telehealth BCBA, and I have no support, and I'm getting injured. Is that contributing? I've never been part of an organization where it was that bad, but I know that exists out there. Is that more commonplace now? Like, is that contributing to this idea that like, hey, maybe we're not a sustainable field as RBTs?
I made the glorious mistake of going on TikTok. Do not recommend 0 stars if you're in your 40s.
No. Right, recommend that as well.
But I had some young whippersnappers tell me I should put some of the questions to my survey on TikTok, which I did. And one of them that I knew was going to be a button pusher was the number of trials we were trying, number of meaningful learning opportunities, I should say, not just trials, but meaningful interactions, learning opportunities per hour. And people went bananas, as people like to do on TikTok. And one of the comments, though, that really just was so jarring, she said, how am I possibly supposed to get that many trials in when my kid is punching me, peeing on me, defecating, smearing feces? And I'm like, of course not. Of course, I would not expect you to be doing those things. And all I could think of course, I have no idea who this lady is, and we'll never know. But like, where is your BCBA? Where is your because this is a technician who was commenting, right? Of course, the expectation is not that. Like, where on earth is the BCBA to help support you so that you're not getting beat up, peed on, feces being smeared on the wall? Shame on that BCBA that you are somehow in this environment where this is occurring and you're still working there. Goodness, give that woman a raise.
I'll also add, though, that I think there's a lot of the BCBAs who don't realize they're working outside their competency area as well. Like, if the behavior is that severe and all you've taken is a real quick assessments course in grad school, that's not enough to know exactly how to intervene on those behaviors or coach someone else through it. And so that's where we often see behavior plans that come to us after they've gone through other BCBAs, and I'm like, this person probably needs a lot more supervision before they're trying to address or tackle these issues. And that's not across the board. I know there's a lot of BCBAs that can do that work, but it may just be the BCBA doesn't even know what to do. It's like, I've been told we still have to get paid for this, so keep going.
I've got a fairly maybe controversial, long-winded position on maybe part of what Kristen was saying. I know, right? On that organizational structure, and where I have an example that I've used, and I'm not going to get too far out in the weeds, but where the way that the organizations have structured themselves to either be the most profitable, be the most salient, or in well-intended serve the most children, it is creating a disservice for us as a field by creating a situation in which all of these things are happening. And where the example that I use when people are talking in person is my children, I call up their pediatrician, and their pediatrician has their hours set. They tell me when I come in. They set my appointment. I don't get to dictate. And where I see a lot of things, and this may have just been organizational structure in moving back to Michigan, but I think it's fairly encompassing of the entire country, where an organization could say, all right, well, we're going to be open from 8 until 4. So we're open only 40 hours. And then they get enough clients or patients going, well, we need services until 6. We need services until 7. We need services until 8. We need services at home. We need services through telehealth. And this was a real big kind of issue for me moving back to Michigan, and especially with the Medicaid system, is essentially the parents were dictating location of service. And it was not based on medical necessity. It was not based on assessment. It was, and again, I understand the struggles in getting to a clinic or getting to your appointments, but If it's this child is going to be better suited, is going to make more meaningful outcomes, is going to reach their treatment goals, isn't going to lag through therapy in a clinic where they can be seen directly by the BCBA on a daily basis, that's where I'm going to recommend. And I think going back to maybe 2 or 3 questions or answers that I'd given before was the organizations have catered to the system instead of making the system cater to the way the organizational service delivery should be to maximize quality outcomes. And so that's been a real big sore spot for me when it's, well, why aren't you determining medical necessity for this? Like, what are the best treatment outcomes? What are those locations? Like, I'm not going to, and I know this is some of the upcoming questions, but I'm not going to do telehealth when I need to see this in person. I'm not going to pick up a VB program and drop it off at your kitchen table. So.
Yeah. Kristen, go ahead.
I want to talk about 2 things, like something that Steve said and tagging on with Taylor, in terms of like the scope and things like that, and what these organizations are just saying, come on in. Like, where is the rule in, rule out criteria for a lot of these agencies of like, oh, like they're just like, oh, you have autism, cool. So like now we have the diagnosis, step 1, and then we're going to do your verification of benefits, cool, pass. Like that's our second checkpoint. And then 3 is like, oh, can you work with us in our hours, which are, like 8 a.m. till 8 p.m. Okay, neat. You're now coming into our clinic, not looking at what are the challenge behaviors, whether comorbid, things are happening. And do we have anyone on staff that's actually a good match for that? No, they just see that, Taylor only has 6 kids and we think a full caseload is 10. So here you go, Taylor, like go do you. Like, I hope this goes well for you. And then we don't have clinicians who are either knowing that this is not in their scope. I think there is some self-assessment that is kind of falling through the cracks, but I also think they don't advocate or don't feel like they can advocate like, hey, I am out of my depths in this case. I don't want to take it. Actually, I don't think a 3-year-old should be getting services from 5 to 8 p.m. because they're falling asleep during sessions and they need to eat dinner and have a bath and see their parents at some point. Like I'm not seeing that level of pushback. And I know that's difficult. It's easier for me to say as someone in my 40s who, runs their own business to say you should push back. But when I look at the BACB data and we see that there's 80 something thousand BCBAs, and there's like 108,000 job opportunities, I would like to say that you are in the driver's seat. Like, you need to push back, because if you don't, you're then going to be, maybe up in front of the licensing board of the BACB, like for doing some really whacked out stuff with a kid that you should have never been servicing. Or we have a kid who's in services for 3 years making 0 progress or potentially making things worse because you weren't willing to say, hey, I don't think I got this.
Yeah, no, absolutely. I remember distinctly back in the early days, somebody trying to make sleeping a target behavior on the kid's behavior plan. I'm like, this kid's 3 years old. We are not making sleep a target behavior on this plan. But to your point too, Kristen, like in terms of even me, if I'm seeking some service like counseling, for example, or like some sort of therapy or something like that, I have a choice in who I choose. I can go to a counselor and say, hey, that wasn't a great fit. I'm going to shop around until I find somebody I vibe with. That I feel like that is something that maybe a lot of clinics don't take into consideration. Like you said, like, oh, you've got availability in your schedule. We'll squeeze you in. You're going to work with an 18-year-old for 2 hours, and then you're going to go work with a 2-year-old. And then, it's just all over the map. And so, yeah, no, 100% agree. Next question, Steve, you're up first. Burnout. I think we've determined maybe an answer to this, but we haven't determined the how. So is burnout preventable, and how?
Yeah, I'm going to take more of the larger picture view of this, because I know Taylor and Kristen are going to talk more about in a center-based type system, the types of things you might do. But again, I think it's all about competing contingencies and how much work do you need to do, or can you give someone for how much money? It's the delayed discounting curve is kind of what we're talking about here. And why not try to maximize profit by growing and serving more people and, paying a livable wage, but also not working people to death, rather than maximizing profits on each individual employee, knowing that you're making their life miserable and now they're going to want to leave the field potentially or find another place to work. And so if we all look at maximizing profits in terms of how much money can we make if we continue to grow because we have a sustainable practice and we're working well and treating people well, I think you'll have a lot more sustained success than how can I make the most money today and put that in my pocket? Especially when we're seeing that, fight back from people who started these big companies early on. They're like, you were getting paid how much per kid? What? And like, you drain the system how much money now? And now rates are dropping all over the place because of it.
Taylor, your take, go ahead.
I think it is, but I don't know necessarily how to do it most optimally, because I think what we're going to run into is what Steve just described, right? I think like for my organization where I'm reinvesting our revenue is to be able to keep caseloads small, to only be open 8 hours a day, to ensure that when we have a cancellation, my staff still get paid, and to ensure that all of those things are there. But like Steve said at the very beginning of the podcast was, I'm only going to be able to pay my BCBAs, $75,000, $80,000 a year. So I can't compete with the company that's paying their brand new, fresh out of grad school BCBAs $95,000 a year. But what I can balance is, hey, you get to leave at 4:00 in the afternoon every single day. We're not working on the weekends. You have a caseload of 6. You have the support of an apprentice helping you. You have low turnover from your techs. So again, looking more at from the BCBA lens. So I think that's how we can do it, at least on the BCBA role. But you're always going to have that balance between, is that person going to be drawn into that 6-figure salary and then have lifestyle inflation creep up, and then not, once they realize, hey, I'm burnt out, I need to go back to that. And now it's like, well, I can't take a $30,000 pay cut. So.
Kristen, go ahead.
I think we need to be real honest with the deficits that some folks are coming into their roles and be proactively supporting them, and not when they're floundering and like underwater, breathing out of a snorkel, to be like, ooh, do you not have this? I do think we need to be actively supporting them in all of their clinical decision making, going back to that point of like, they've maybe only learned how to make craft dinner, and we are now asking them to be an executive chef, and they just don't have that skill set. So I think we need better tools to help, I guess, kind of assess where they're at when they're coming into any position, when they're taking on any client, and help guide them through better clinical decision making with resources, with knowledge base, so that they're not overwhelmed and underwater all of the time. Because when they're stressed, you best believe all the people that they are supporting are then stressed, right? Because they're not going to meet their deadlines. They're not coming to supervision prepared, because they are just running around with their head, their hair on fire. And so I think that there needs to be significant training, skill deficit backfilling. How's that?
Taylor, this one's yours first. Telehealth, let's talk about that. Strengthening access to services, or is this part of the problem?
Remember, 1 minute.
It's 99% part of the problem. I think there are those outliers and those nuances where I'm living in rural Alaska. I just drove back through rural Nebraska, and it's like you can drive for hours and not even come into a town. Okay, telehealth, yes, but even then, the degree of clinical quality, and I'm talking only about 97155, so adaptive behavior protocol supervision modification, you are going to miss so much. And it's going to be the most important clinical nuances that you're going to miss. You're going to miss those stimulus control errors that are creeping up because of any number of things that you're not going to be able to get with either the cameras in the corner of the room or the tech following the kid around with his iPad showing the camera. It diminishes the overall quality so significantly that my stance on it is that it is not clinically justified to be able to provide telehealth services unless there's medical necessity that warrants it.
Kristen, to you, go ahead.
People are not going to like my answer, but I agree with Taylor. It is, I think, become really problematic. I mean, obviously, all this came out of COVID, which was very much necessary, right? We were working in unprecedented time, and I think during that time, folks were really rushing to try and help and like guidelines and what can we do and how can we make it better? In terms of what equipment do you need and what kind of safety precautions, security, HIPAA, that kind of stuff. But then all of that just kind of stopped. And when you ask people, I've seen so many agencies don't think about how you need you need two iPads, one for the tech to take their data, and then the other one just for the video transmission, right? They need earbuds, right? So that they can be listening to you as you're talking. We have kids who are very much responsive to electronics. Like, what kind of other devices could we be putting? What about a body cam so that they're not trying to play video, choreographer kind of thing? I'll zip it. I'm at my minute.
Steve, we'll see if you can compete with Devil Kristen. Go ahead.
I don't need the horns. They're just there all the time. I 100% agree with both of you as well. And Taylor, I think you hit it. Remember the earliest examples of this, there was, doing the FBAs via telehealth in like rural Iowa.
Yeah.
I know Stephanie Peterson.
I was actually, while we were on the first question, I was actually Googling to see if I could reference the paper, the original one.
Yeah. And it's when you don't have another option, it's a great option. But I just think about when I'm going in and do a functional assessment, the small nuances, who's sitting where, who's saying what, who's rolling their eyes that I might not see. Or going back to many years ago, my time in an autism center, where I remember one instance where I thought I was the man. I had this kid, I was teaching him everything first trial. I mean, it was amazing. Like, oh, select this, doing it perfectly. And then realized that nobody else was getting the same results. And so I go back and really I'm attending to it, and I see I'm looking at the correct answer, and that is enough to have the young man be able to attend to that and select the right one because I'm giving him the answer. And so if you can't pick that up because you're not in the room and seeing those small details, then there's a very good chance you're not giving the level of care you think you're giving. And so if there's no other option, great. But otherwise, I say I have no interest in it at all.
Taylor, I saw your hand first.
I was going to say, Steve, I have an identical example that I still use with my apprentices here when we're talking about stimulus control. 100%. But I think oh crap, I lost my train of thought. Darn it, Steve. You messed me up. All right, go, Kristen. I'll think of it and I'll come back to it.
It's her curse. It's the devil's curse.
Yeah,
that's right.
Okay, go, Kristen. I'll think of it. Oh, I remember what I was going to say. I think, though, that with that early research, that is an example of where it's been mistranslated and misapplied, because that early research was meant to be informative of, and I think it was even predated BCBAs, but that was to be informative to the behavior analysts to guide treatment decisions, because they couldn't travel 4 hours to rural Iowa. So they're watching up in the corner, guiding the parents to implement the FBA or the caregivers and going, all right, we got our FBA results. That just helped us to be able to determine what our next steps in treatment were. It wasn't supervision of direct care treatment. And so I think we've taken some of those early situations in our research and applied it and said, yeah, see, telehealth works. We can do telehealth. And it's really, again, in my clinical experience, it's really not. Oh, Steve, what's up with the hat?
He's felt jealous that I have props and he doesn't. I have a whole basket, Steve, so watch out.
Okay, all right. So sorry to cut you off, Kristen. Go ahead.
No, you're good. I think the other piece, if you are going to do it, because to Taylor's point, there are certainly some areas where you're just not going to get a BCBA to go, or you're not going to get them, maybe they can, like every other supervision, right? Like one's remote and then the next one's in person or something like that. But if you are going to do it, I think folks need to be very cognizant of the skill set that is very different from doing that in person. And I think every college, university professor that taught pre-COVID and then had to very quickly adapt to distance learning during COVID can attest that it is not the same thing. Being a remote instructor is so different from doing that in person in front of a classroom. And I don't think BCBAs have gotten that piece at all. And I have now seen requests for they want to get their hours, their supervision hours remotely. So never mind, do I want to be a remote supervisor when I've been certified for 2 minutes? But I also now, as a candidate, a supervisee, behavior analytic trainee, want to get those remotely. And I am very concerned at that trend that I keep seeing. I got a LinkedIn recruiter, hey, come, I'm in Arizona. Our license is a pain in the ass to get. So lots of people want me to all work for the agency just because of my license. And they're like, hey, we're offering 100% promote. And I'm like, this is a huge red flag. If I was looking for a job, I wouldn't come because of that. And he misinterpreted and thought I was lying. He's like, no, it really is 100% remote. I'm like, you're not listening. This is awful. But I'm seeing that now as a lead magnet for businesses, that you can do all these remote hours and things like that. And we're not considering the skill set of the person who is going to be directing that type of telehealth service or the type of equipment. Like bare minimum, people aren't even thinking about equipment, which is just so shocking. And then we're certainly not thinking about the skill set that we need to be able to implement that appropriately.
Yeah, and I've got maybe one more follow-up to that in the sense that when I see these on the subreddits and the Facebook groups, right, and it always creates a lot of contention and argument with respect to this, but I think where I'm regularly seeing from those advocating for it, I've never seen actually it advocated for it increasing the quality, right? So to tie that back to our topic for today, it allows me to see more people. It cuts down on driving. It cuts down on reactivity, blah, blah, blah. And again, generally when it's in-home services. But none of these arguments for this is why I support this has been tied to or related to it improves clinical outcomes. It allows the children to reach their goals as effectively as in person, or like all of that's missing. And I think while all those other arguments are potentially valid, we're missing the most important elephant in the room of the reason they're in therapy is to get their symptoms treated. And we're not doing that as nearly effectively as we could were we in person.
As a business owner, I'm seeing improvements because it cuts drive time out of the equation, and I don't need to pay for or have the liability of drive time. And I also, as a BCBA, if I overlook all the amazing points that all three of you have just made, I can see more people, and I don't need to go in person, get down on kids level and hurt my back and roll around and potentially face difficult behaviors in person. So is this something that, well, I think I know the answer. We're doing this because it's a cost saver, or it makes companies money faster, and I can pump this out, but it's also attractive to the BCBAs, I think, that might not have the lens that you are framing. Does that make sense?
Mm-hmm. But I think, like, in terms of the appeal, I don't think that they are. I mean, if you haven't noticed already, I really like decision models, kind of my thing. So in terms of like a decision-making framework of like when it would be appropriate to use this, not just from a distance perspective, right? But maybe there is really, huge reactivity if another person's in the room. So we want to have the little nanny cam in the corner kind of thing. I don't see people using that. Like, so think about telehealth for medicine, right? My daughter, a couple years ago, she had pink eye, right? I mean, you could see it, red, goop, gross, and of course it's Saturday, so nothing's open. So we did a telehealth appointment, and you can put the camera right up to her eyeball, and they're like, yes, that is clearly pink eye. Let me write you a prescription for some drops, right? But if I have an earache, that is not going to go very well on my iPhone, right? You're not going to be able to see in my ear and see if I have some kind of debris or like an inner ear infection or like whatever they're going to use when they have a scope and like those types of tools and stuff like that. And so I'm hoping that most doctors would say, hey, I'm really sorry, but you need to go to in-person clinic, urgent care, because it's Saturday, to go rule out what type of ear problem you were having. And they're not just guessing and like doing that. Maybe, I don't know. I hope that there's better decision making. So that's what, if we're going to go and continue and support, which I think a lot of Medicaid, if you guys are following up what's happening in North Carolina and other places, like there are going to be some rules coming around the telehealth. But if we're going to continue to offer it, I think proactively, like we should be working on those decision frameworks of like, when is it appropriate? When is it not? How are we determining that? And then if it isn't appropriate, still like, are we checking? Is it still the most appropriate? Is this still the best way? Are we getting the outcomes we anticipated? Because I think the BCBAs who are doing telehealth are just as they have just as much probability of becoming burnout because they're not going to see the success of their clients because things aren't getting better because they're not being able to manage skill acquisition and challenging behavior remotely the way that they could in clinics. I think there is still a huge risk for burnout. Just because you're not driving is not going to be the linchpin that like solves your life's problems.
I will add just real quickly too that it's not that we never allow our employees to use it, but there's an illness in the home and staff can't accommodate you, but it's better than not showing up at all that week. Or the weather's real bad. Can we get on a video so at least we can provide you with some support? And so I do think finding those reasons, those exceptions, but making it the rule is where it gets so dangerous.
But see, that's what's coming though. If you guys follow insurance, like then there's just going to be those blanket rules of like, there's no more telehealth, just nope, gone. And so then the folks who, for your good example, Steve, or the rural folks or those who don't live in an area where BCBAs come, or we have a immunocompromised kid where we want to keep them safe, all of that goes away. So if we're not being proactive about how we're making these decisions, I think funders are just going to be like, sucks to be you. It's gone now for everyone.
Also, this is my Mayor Humdinger hat from Halloween a year and a half ago. That's what.
It's a really important point. Important rebuttal there. I was stoked that you kept it on for so long.
I had to wait till to explain it.
Last question before our final take-home points. Let's talk about private equity. Are private equity firms part of the problem or part of the solution? And Steve, we'll start with you first.
All right. They are not all a problem, but they are certainly a big chunk of the problem because they are the ones who don't need to see as much profit from a single, a code or a single unit, and can still pay real high as long as they're getting the money out of them eventually and maximizing profits today. And I think the maximizing of profits and looking at it from that perspective is the biggest issue as well. And take it outside our field, look at like the restaurants, and you have Red Lobster that, all right, we can maximize profits by, giving you tiny shrimp. The quality of service goes down. The food sucks now, but hey, at least we're saving so much money that, we can still charge the same amount or a little bit more and look at all this profit we have for 1 or 2 years until people stop showing up. And that's the bubble I'm talking about. People are going to stop coming to us for help because our quality of care is falling down because people are burnt out. Even though they're making a ton of money, it's just not going to be there because they're not trying to make it sustainable. They're trying to maximize profit today.
If I was giving points, Steve would get one for successfully incorporating Red Lobster into conversation meaningfully. Taylor, we'll go to you next. Same question.
Yeah, I think even Steve's analysis might be a little bit misaligned in the private equity space with his, we can make less. Because I think when you're beholden to investors and you're beholden to paying back your investors when they invest in your operation. And so I think at that point, the problems that we run into are things like what I've kind of been describing earlier in we can make adjustments to where we're open later. It doesn't matter if I have 300% turnover on my techs, as long as I've got a tech in that space, providing that service, and I can bill for it, I can make all of those other cuts in things like I can bump up the BCBA's caseloads. I can be open 12 hours a day. I can have a bunch of part-time staff that are only making $14 an hour and only working 12 hours a day. And when their client calls out, we're not going to pay them. And it doesn't matter because we're not even going to develop the organizational systems that ensure parents and clients are showing up every day, because it doesn't matter in that regard because I can just send the tech home and that saves me money. So I think maybe on a more global aspect, the private equity firms have to pay their investors back. And so I think they need a larger margin of profit.
Kristen, bring us home on this one. Devil hat, it's out.
Yep. So I'm going to say it's a double-edged sword because with money, right, there's sometimes access to more resources. So I have seen larger organizations be able to have things like sometimes grand rounds teams where they're consulting with a psychiatrist or feeding specialists and OTs and things like that for maybe some complex cases that maybe a smaller clinic could not take on. So I see that sometimes it happens. However, I do see all the things that kind of Taylor and Steve have talked about. And I think one of the bigger issues is some of those salaries, like we can offer you a $20,000 sign-on bonus, and it does really hurt the other mom and pop shops that like obviously can't compete with that. Not to say though that the answer is every ABA company needs to be owned by a clinician, because I've seen ABA, like BCBA owner clinics not go well either. So I don't think it's this binary PE is bad, clinic owned is automatically good. And like, that's just what we do from here on out. I think unfortunately there's a lot of gray in that area.
Yeah, I'll say, I think a lot of the time you still have to remember maximizing reinforcement, whether it's a BCB owned or not. If you can make more money doing something, you're going to be hard press not to do those things, even though hopefully you'll be a little bit more aware of how it's affecting your quality is the difference. But Taylor, just to go back to what you were saying compared to what I was saying, I think you misinterpret a little bit. I'm talking about the amount of money we're paying the BCBA, which means per unit, the BCBA is bringing in less money, but overall they're getting more money and more profit.
Yeah. Okay. That makes sense. Yeah. Okay. Yeah. I definitely did misinterpret that. But I think I've got to Kristen's point, and maybe this will be the last words out of my mouth. And this is word of mouth. I don't have the sources or anything, but I remember hearing about Doreen Graham-Pisha, who sold card, and this is I saw this on Reddit, or I saw this wherever, that her intentions were this private equity company is going to be able to inject all this money into this organization to be able to help provide more services, better services, reach a wider audience of individuals. And she ended up buying it back because it nosedived and didn't end up doing that. So again, that whole story, I think that was just word of mouth. I don't know that for a fact, but like that sentiment echoes for me in a lot of different areas where I don't see, but I also don't see a way around it, because that's the way hospitals operate. That's the way a lot of the healthcare industry operates. So I don't know a way around it, because as a mom and pop owner, like I'm not going to scale to providing services in 10 different states and having thousands of employees. So I don't know what the solution is.
I wouldn't be opposed to scaling like that. I don't know if it's ever going to be in the cards, and I'm not going to try to do it without making sure I can be sustainable in the services I provide that way. But I do think, and this goes back to what I said in the very beginning, is it is a cultural issue. It is our society as a whole. It's part of being based on money with everything we do. Where, I mean, we even take it back, coming from the Detroit area, the big three car companies, and they're outsourcing jobs to places where there's cheaper labor, not even considering the fact that we import way more than we export in this country. And if you want people to buy your products, then the people here need to make the money to buy your products. And so you're giving, business owners all these cuts to save money and show more profits because legally they have to, yet 5, 10, 15, 20 years down the line, no one can buy what you are selling anymore because there is no middle class. It's all nothing or everything. It's, haves and have-nots. There is no middle ground. And that, I think, is kind of where the same model we see here going down the line.
Kristen, go ahead.
I just want to, I'm going to challenge you a little bit, Steve, that I think there's multiple competing contingencies for why folks are going to somewhere like the bigger name folks, like outside of just money. Cause I've also seen folks who are maybe like underinformed of like, what does it really mean? Like to bill 30 hours? I'm in a clinic for like 40. That should be easy, right? Because maybe they just weren't brought up in that system. I did a LinkedIn poll not that long ago, and there was like 240 people, and like, why did you leave? And so like, maybe they're going there for the money, but they're not leaving to get paid more somewhere else. They're leaving because they're not proud of the service that they're providing. So I think some of it, maybe they start there, and then hopefully they are like, ooh, this is why I got a $20,000 sign-on bonus. This is how they have to pay this to get people to even come here. So I think there's multiple competing contingencies, and I don't want anyone to walk away from the call thinking like, we all know that you only care about money BCBAs. I don't think that's true. But I do think there are, if you're coming out of school, you have loans, depending on like your cost of living for where you're working. I do think that is another piece of telehealth that we maybe didn't mention either. Like if I can live in a state that has really low, property, like, costs and stuff like that. And then I can telehealth into other, markets that can pay a lot more, then perhaps like that's very nice. I can go and get $120,000 a year. My cost of living is really, really low. There is, I think, there's a lot of competing contingencies, I guess. I'll leave it with that. There's a lot of competing contingencies to controlling behavior.
I completely agree with that. I think even just the idea of working for a big company that you're familiar with, you've heard it before, it's legitimate, is a big piece of it as well. I will just say, when we have someone come in here and see, the quality of life and how it differs from some of those other companies, even if we can't always pay what a lot of them are paying, the larger ones, they're like, I don't care. I'm not leaving because this is just nice. I can do my thing. I can help people, and I'm not feeling like I'm being worked to death And so that's kind of where I'm coming from, is the feedback we get once someone comes to us after being at one of those companies.
But you have to have the opportunity to present that though, right? Like if people doesn't everyone take the interview with you because they only, I've never heard of who's Steve Sparks, who's this guy, right? Yeah. If you just can't even get them in the door to get there, I think that's where, PE they have a big marketing budget, right? To be able to get people into those hiring events, all that kind of stuff. If you can't get them to even experience what you have to offer, it's a problem too.
I'll say, coming out of school, I would have taken the money for a few years just to save up some and then gone and worked somewhere else or pay off my student loans or whatever, just so I could then have quality of life without it hurting me too. So I can't blame the BCBAs that are doing it. It's the system that we need to do something about.
Well, I think we'll wrap things up there. This has been a great discussion. Thanks, Steve, Taylor, and Kristen for joining us today. We'll be back, I think, for a lot more of similar conversations. So happy to have you guys here. This has been another, or I guess I should say the first episode of Behavior Business Roundtable. Thanks so much, everybody.